Turn that down a little bit. All right, how's that? Well, thanks for coming out tonight. We're going to talk tonight about respiratory emergencies. Glenn was in and left the sign-up sheet, and we're working on next year's schedule to be compliant with OEMS. And so I think we've got a couple more talks this year, and then we're putting together a schedule for next year, very similar, where I'll be doing 6 of these events, and they'll be doing 6 on-site skill stations. And the question will become whether we continue to do them here or whether we move to some venue that's a little more convenient for everybody and we don't worry about recording them and so forth. So I think that'll be a discussion for another time. So anyway, tonight, the resources that we used, if you guys have access to the textbook, Advanced Medical Life Support, really good book, to have around. But what we're going to talk about tonight are respiratory emergencies, particularly as they relate to asthma, COPD, and pneumonia. And you're saying, why those things? Well, they're so common that we see them almost weekly in our business. We could talk about anaphylaxis and congestive heart failure, but those are almost separate topics in and of themselves. So that's what we're going to focus on tonight. Before we get in there, we're going to talk about some definitions and diagnostic stuff, and then we'll get into actually the cases themselves. But when you talk about breathing, you're talking about ventilation and respiration. And ventilation is simply the movement of air in and out of the lungs. And that's a function of our chest wall and the ability to expand and contract. And what you're trying to do in ventilation is deliver clean, humidified, temperature-controlled air to the alveoli, to the lungs. And our body is just amazing in what it can do to a temperature of air in our nose or our mouth. By the time it gets into our upper airways, it's the same temperature as our body. It's humidified. And so ventilation is moving air in and out. Good air in, bad air out. Respiration, by definition, is gas exchange at the alveoli. The alveoli are the tiniest sacs in the lungs where actually gas exchange occurs. And that's where oxygen is taken out of the air we take in, goes into the bloodstream, and carbon dioxide, the waste product from our body, is removed from the bloodstream and we breathe it out. So ventilation, movement of air, respiration, gas exchange. So when we talk about respiratory problems, what is respiratory failure? We'll hear people talk always in respiratory failure. There really are 2 types. One, it's either low oxygen or high carbon dioxide. So we need the oxygen in, but what we don't want to also do is build up carbon dioxide. So when we talk about hypoxic respiratory failure, we're talking about the inability to extract oxygen from the air that we breathe in and get it into our bloodstream. So if you take those alveoli, those tiny little sacs, which are 1 cell thick, and the blood runs through them, if you fill those alveoli up with pus or blood or fluid, so pus would be pneumonia, fluid would be congestive heart failure, then you can't get oxygen into them to diffuse into the blood. So that's hypoxic. You can't get the oxygen into the bloodstream. The other type of respiratory failure is more common that we see in COPDers is hypercarbic. Hypercarbic means high CO2. And that is we're not ventilating well. So we've got a failure with hypoxic of exchange of gases. But in hypercarbic, that is the CO2 is going up, the carbon dioxide is going up. That's ventilation failure. And that's something that occurs, for instance, in your COPDers. So when we talk about the anatomy, remember that our upper airway is everything above the vocal cords. We're talking about the nose, the mouth, the posterior pharynx, all those things that you can basically look and see. That's our upper airway. And there's a whole set of illnesses that can cause respiratory distress associated with air. For instance, angioedema. We've talked in our talks before about anaphylaxis and swelling of the upper airway. That could happen there. Our lower airway, trachea, bronchi, lungs, the bronchioles and alveoli. Trachea is a hard pipe that basically delivers. So really no gas exchange goes on there. The bronchi are the branches, and you can get mucus built up in there, the definition of bronchitis. The bronchioles are the smaller branches, and the alveoli are the end of the line where gas exchange occurs. And like I said, when the alveoli become dysfunctional, either because they've got products of inflammation, pus, or they have fluid buildup in them, they don't work. So how do we get air in and out? It's really a pretty simple process. If you take a cylinder of a certain size and you put air in it, you cap it. If that cylinder gets smaller, the pressure inside goes up. Makes sense. Likewise, if that cylinder gets bigger, pressure inside goes down. It's exactly the same with our lungs. The way we move air in and out is by pressure changes in our thoracic cavity. So as our diaphragm, which is the big muscle between the abdomen and the lungs, that thing's dome-shaped. And as it contracts, it flattens out, and it kind of expands our pleural space down. At the same time, the muscles between our ribs contract and cause the chest wall to expand. Well, that's increased the size of our chest cavity, of our pleural space. The volume goes down, or the pressure in the chest goes down, air comes in. Whole process then reverses. Those muscles relax, the chest cavity becomes smaller, air goes out. So it's really pretty simple. The problem becomes when we get air trapping and things like that, we're going to talk about in just a minute. So when we talk about what the things we're going to talk about tonight, asthma, COPD, pneumonia, two of those illnesses are air trapping diseases. That is, we can get the air in, but we can't get it out. And that's what happens in asthma, which is a reversible air trapping disease. Hopefully it's reversible. COPD is pretty much non-reversible. And then there's infectious pneumonia. So when we talk about air trapping, what do we mean by air trapping? Well, let's say that we breathe in, pick a number, we breathe in 100 cc's of air. And because of inflammation or mucus plugging or whatever, we take in 100 cc's of air at a breath. But maybe we only exhale 99.5 cc's. So every time we breathe in, we're keeping just a little bit more air. And that's called air trapping. So over time, it's like blowing up a balloon. You know, the balloon's really compliant and it's easy to put more air in. And then as it gets bigger and bigger, it gets tighter and tighter. And finally it reaches a point where you can't get any more air in and that thing's really rigid. It's exactly what happens in air trapping diseases in our lungs. Infectious deals with pneumonia. And that's not an air trapping disease. That's a disease where the alveoli have junk in them, infection, and they can't exchange oxygen. And interestingly, in pneumonia, it usually is in a certain area of the lung. So it's a lobar pneumonia or a segmental pneumonia instead of a diffuse process like congestive heart failure. So you'll get a chest x-ray and you'll see one spot where one lobe or one little part of the lung is involved, and in that area there's not a lot of gas exchange going on. So when we talk about looking at patients who are in respiratory distress, everybody in this room, based on your experience, can walk into a room, and before you ever count respirations, before you ever put a finger pulse oximeter on, before you ever take a pulse, you can tell if that patient's short of breath. And you do. You go walk in, you look at them. You know, hey, how you doing? They can't talk to you. You know, they're talking, and that's a measure that we use in documenting in charts. The patient could speak in 3 or 4 word sentences versus, you know, I'm talking along now in normal tone, but all of a sudden the patient's saying, I am, you know, he's speaking in 2 and 3 word sentences. Well, you know that as soon as you ask them, hey, how you doing? What's your name? They can't talk to you. Are they breathing fast or slow? You walk in and you look at somebody and you watch them sitting there and they're huffing and puffing and you ask them how they're doing and they can't talk to you. If you pull their shirt up, you see them using, you know, when you breathe, our chest wall is nice and smooth, but all of a sudden you see the spaces between their ribs are retracting or their abdominal muscles are retracting. That's the use of accessory muscles. Those things you can pick up real quickly before you ever even start taking vital signs. And then the other one is what position are they in? Someone who's really short of breath, particularly with pneumonia, congestive heart failure, they can't lay down. When they lay down, they get worse. And these people are sitting up, and many times they got their arms out. They're tripoding where, you know, they've got 2 arms out and they're sitting on their butt, and they are not going to. They don't have enough energy to move around, but they're darn sure not going to lay down because they can't breathe. So, you know that when you walk in the room, you can look at the work of breathing. And that really is an indicator right there before you ever start taking vital signs, kind of the condition of the patient. So when you see that, then there's some important questions that you ask. And you either, you know, while someone's getting oxygen on the patient and doing those kinds of things, some questions you ask, hey, have you had any fevers or chills? Patients had fever or chills recently, you have to think infectious. You have to think pneumonia. All right. So this guy's been coughing for a couple of days, and his wife says last night he had a temperature 102, 103, or he felt hot and he was sweating. Well, that tells you this is probably infectious. So he's probably going to be hypoxic. Ankle or leg swelling. What do you see then? Someone with congestive heart failure. We see this all the time. You know, these guys that maybe they didn't take their fluid pill. Maybe it's Thanksgiving and they just had a salt-laden Thanksgiving dinner and now they've got all this extra fluid on board. A lot of these people will tell you, they weigh themselves every day, says, I don't know what's going on, but I've gained 6 pounds in the last 3 days. Well, 6 pounds is about 3 liters of fluid. Now they're short of breath, their legs are swollen. That's pretty simple. We know what's going on there. Do they have a cough? You got cough, fever, chills. All right, got pneumonia, but you can get a cough with any of these respiratory problems. Anytime you get a little fluid, you get a little inflammation, you tend to cough. Someone who's been coughing for a month, 6 weeks, you have to think of inflammation of the airways, like asthma or allergies. Orthopnea is sitting up on the edge of the bed at night. You know, they can't lay down. They're sleeping propped up on 2 pillows, 3 pillows. You know, they go in and you say, man, the last 3 nights I've slept in the recliner. I can't sleep laying down. Normally this guy can walk to the mailbox and back, but the last day or two, I can't make it off the porch. I get short of breath. You know, those are good questions. How far can you normally, when someone says, I can't walk to the mailbox, it's like, I can't play the piano. Could you play the piano before? You know, it's like, well, you know, I can't walk to the mailbox. Well, how far could you walk a couple days ago? Man, I could go down and back 10 times. Okay, that's a change. And then obviously history. You know, do they have a previous history of asthma? Do they have COPD? Have they been coughing up blood? You know, that could be infectious or a number of other things. Big questions always, are they a smoker? And many, many times in our respiratory cases, yep, there's a smoker. You walk in, you see an inhaler laying around, you see a nebulizer. Hey, how often you've been using that? It's amazing that even with the advances in medical care, the deaths from asthma continue to go up because we've got some really good medicines, we've got some really good delivery systems. And unfortunately, what that does is let these patients sit out there and keep puffing and puffing on a puffer until they've air trapped themselves into real problems. So these are questions to ask. So you walk in, you see how they look. Are they really working hard to breathe? And then you ask some of these questions. And those questions can really guide you. Do you think this is pneumonia? Do you think it's asthma? Do you think it's COPD? What do you think is going on? And then we talk about, well, how bad are they? Are they in trouble? Are they short of breath? or do they have impending respiratory failure? This is a patient who's going to just crump on you in the near future. So, if their respiratory rate's real slow, it's less than 6, it's less than 30 or more than 30, they're in trouble. If you put a finger pulse oximeter on, their oxygen saturation is less than 90%, they're getting in trouble. All of us in this room right now, if we put one on, are 95 or greater. You get 94, and otherwise healthy people, it kind of gets your attention. You get to 92, it's like, yeah, this is fairly significant. Now, COPD will be at 92 all the time, but us, 92 is a bad number. And pulse oximetry is interesting because it's complicated on what they call the oxygen hemoglobin dissociation curve, but the bottom line is 95 is the number that all adults should be better than, and kids. And once you start dropping off, you go at 95, your oxygen saturation, if you did a blood gas, is 90 to 100. But when you drop to 90, your oxygen saturation is down around 60, and you feel short of breath and you look short of breath. So when you start seeing people with oxygen saturations of 86, 88, 90%, they're potentially intubation material. You get someone with a SAT of 70, 75%, they're really in trouble. So once again, low oxygen saturations, use of accessory muscles, can they lie flat at all, or heart rate, bradycardic or tachycardic. Altered mental status, if you're hypoxic, you're not thinking straight. Your brain requires glucose and it requires oxygen. If your oxygen saturation is low, I'm confused, and we joke, in the hospitals of how many interns have gone to a patient who is confused and killed them with Ativan or Valium when what they really needed was 2 or 3 liters of oxygen. And, it's a fact. So when you see altered mental status, change in mental status, a lot of things you think of, but one of them is, are they getting enough oxygen? Are they unable to, clear their secretions? If they're coughing and they get this deep, the death rattle where they don't have enough cough to be able to get stuff out. Skin color changes are important, but they're late. If you look at somebody, it's always important when you go into these houses to try to look at their lower extremities, because people get mottled. That is that blanched, that purple look of just it's cyanosis, but it's the mottling, and it works its way from the feet up. And so, you go into a bedroom, you pull the sheets back, and all of a sudden you see that this patient's just mottled from here down. Well, they're either lacking circulation, or they're lacking oxygen, or or both. And those patients are the ones that need fluids, and they need oxygen. They need it in a hurry. When you listen to the lungs, if we listen to all of us right now, you breathe in, you breathe out, you really shouldn't hear anything. You hear air moving, and there are no noises. But when you get inflamed airways, and those airways get inflamed and swell and narrow down, and as that air passes through, it wheezes. When you start filling up those alveoli with fluid and you breathe, it's almost the fluid in that alveoli is bubbling, and it crackles, rows. And we talk about, we can hear rows at the base, we can hear rows halfway up, we can hear rows the whole way, as in congestive heart failure. So that patient's breathing, and they're moving air into those alveoli, and it's almost bubbling that fluid, if you will, and that's what you're hearing in those rows. Rhonchi is more upper airways, so you've got some mucus, you've got a bronchitis, and you've got some mucus and junk build up in the bigger upper airways. You breathe in, you can just hear all this stuff kind of gurgling around, almost a snoring sound. That's rhonchi. Stridor is the one we never want to hear, and it's more often in kids, and that's from narrowing of the upper airway. So, for instance, in an angioedema, an upper airway obstruction, it's always on inspiration. The patient's taking it in, all you can hear is this whistling, high-pitched sound as the air passes through a swollen upper airway, and those are the people that are getting in trouble quickly as well. We've relied on pulse oximetry for years, and I talked about this briefly a minute ago. And it's interesting the way it works, because what it does is it passes a light into the soft tissues, and that light reflects back, and it's looking to see how much of the hemoglobin is saturated with presumably oxygen. So it's taking this saying, okay, 95% of the hemoglobin is saturated. And that's an approximation. But what it doesn't say is what it's saturated with. It could be saturated with carbon monoxide. But most of the time, we're looking at oxygen saturation. So the normal is above 95%. When we start getting down into the 92s or the 90s, our oxygen level in the blood is really starting to drop off. And so the point I'm making is that small changes in your SaO2, the number there on that pulse oximeter, small changes in that number are big changes in the oxygen content of the blood. And so again, 95 is the number we want to see. 92 is a little worrisome. Below 90, it's not like taking a test where 90 is an A. You know, pulse oximetry, 90 is a bad number. So let's talk about asthma. Real common illness. You know, 20 to 30% of all hospital admissions every year, typically in the fall and the winter more than any other time, are due to asthma. So we're coming into, in the near future, big asthma season. High relapse rate. If you've got asthma, you're probably going to have problems again. Somewhere, around 10% of the population has it. And as we have worsening air quality, there's an increase in asthma. So you see there's an association with childhood exposure to secondhand smoke, indoor air quality with molds and so forth. Air quality outside, particularly, if you live in a major city where the air quality is not that good. So all those things contribute. The thing is that the earlier the age of onset, probably the worse the long-term lung function is going to be. So we see some kids who have onset before, age 5, and they may have problems for a long, long time. When we talk about asthma, we think of wheezing, but a lot of these people begin developing, they'll get the feeling of shortness of breath, and they get some tightness in their chest, like they just can't get a good deep breath. A lot of times they have this dry, hacking cough, and they'll come into the emergency department of the clinic and say, I've been coughing for a month. I can't get rid of it. I've taken all kinds of cough syrup. Get anything up? No. Fevers and chills? No. Feel a little short of breath? Yeah. And it's just this dry, hacking cough that's coming from inflamed airways. Wheezing's kind of the hallmark, but a lot of times you'll see people that every time they get a viral respiratory infection, they get wheezing. A lot of people get exposure to allergens, so we're coming into that fall season for allergies. A lot of people have problems. We've got folks who get exposed to perfume, which is why in healthcare, it's really, you don't wear colognes and stuff because you walk in a room, you can trigger someone's asthma attack. There are people that sensitive. So a lot of things can trigger it. Wheezing is kind of the hallmark. So you've got to treat, when we treat asthma, the thing that we used to miss, it was interesting, when I was in training in the 80s, we were withholding steroids until the most severe cases. And that's when albuterol was just coming on the market. We know that with asthma, there's inflammation of the airways, there's mucus production and mucus plugging, and that leads to bronchospasm, those airways spasming and wheezing. So if you don't treat all of those components, the patient's not going to get better. So what generally happens is the patient gets exposed to one of their triggers. They begin breathing a little faster as that inflammation develops. The airways narrow. Now we start getting a little air trapping. So every time they breathe in, they're not getting as much out as they took in. And then the airways begin getting stiff and the work of breathing increases, and that's when wheezing develops. The patients that die from asthma are the ones that let themselves get far down the road to where they have respiratory failure. And the ones that are toughest to manage on the ventilators in the hospital are these guys because they've got air trapping. They can't get it out. You can put them on a ventilator. You can put a tube in. Now, what do you do with your ventilator settings? You get a very small amounts in. You're trying to get more out. They suddenly go down the crapper because they dropped the lung. You know, basically the balloon burst, and now they've got a pneumothorax that you got to deal with. So the folks who sit out there and let themselves develop over weeks are the ones that can get in trouble. So we talked about triggers and causes, exposure to allergens. You know, some people are allergic to cats or dogs or whatever, ragweed, pollens. Obviously, the business that we're all in, inhalation of smoke and particulate matter, our bodies are really, really good filter, but it can only filter so much. Some people get exercise-induced asthma, you know, from vigorous exercise, or you might have a distance runner who goes out on a 10-degree day and they get cold air induces it. Many, many cases it's due to viruses and upper respiratory infections. So when we talk about kind of critical asthma flares, those people have low oxygen saturations, they're breathing fast. The ones you worry about are the ones, you know, it's a question you always ask when you're asthmatic. Say, have you been in the hospital recently for asthma? Yeah, I just got out last week. Have you ever been on a ventilator? Yeah, I've been on a ventilator 3 times. It's like, ugh, here we go. I mean, those are the ones that really are going to have the potential to get in trouble. And again, you go back to what we talked about earlier. You look at accessory muscle use, you look at how long they've been having problems. And the issue that I tell patients is, look, the longer it took you to get here, the longer it's going to take to get better. And that's true of virtually everything in the body. It's like the longer it took to get where you're at right now, the longer it's going to be your recovery time. And a lot of these people, how often have they been on steroids? And some of these folks literally become steroid dependent over time. So when we worry about who is going to really get in trouble, we just talked about it. How many ICU admissions have you had? How many times you've been intubated? Have you been in the hospital more than a couple times in the last year? Those puffers that you use should last 3 months. If they're going through a couple of them a month, that means they're inhaling this thing every 3 or 4 hours because depending on whether they got 60 or 90 puffs in them or whatever. And then, you know, you get into the cases where we know that patients get sicker if they don't have the means to get to a doctor, lower socioeconomic status. So they don't have perhaps the education that they need for their illness. They don't have the access to medical care that they need. They're drug users. If they have psychiatric disease, I don't need this medicine, you know, whatever. Those are things that increase the risk factors for dying from asthma. Inhaled beta agents are the mainstay of treatment. What's a beta agent? That's albuterol. It dilates the airways. The other mainstay is steroids, whether it be by mouth or injectable. Ipratropium is Duoneb. It's a kind of dries things up, if you will. Oxygen if the saturations are low, and magnesium. So we talk about inhaled beta agents. We carry albuterol in virtually every EMS unit in the country. A beta agent, albuterol, for instance, the prototype, dilates the airways. So that reduces the spasm and reduces the wheezing and lets air move in or out. This has evolved over years as well to where, you know, we used to give a treatment every hour. Now, you know, patient comes in, you know, we'll mix 4 of these, 2.5 milligrams each. So 10 milligrams, put it in one of the containers and just let them run over an hour. But the point is, you talk about patients that need admitted to the hospital. Generally, the criteria is 3 to 4 aerosols with no clearing. Their admission criteria. So when someone comes to the emergency department, they get an IV put in, they get a little bit of fluids, they get some steroids, they get 3 treatments, they're still wheezing, they're still short of breath, their oxygen saturations aren't great, they're probably going to need to be in the hospital. Ipratropium is an anticholinergic, bronchodilator, dries things out, if you will. It's a little better for people with COPD, but we carry something called Duoneb, which is ipratropium and albuterol. You give it exactly the same as you put it in an aerosol and give it. IV steroids really have become the mainstay of treatment, just like we talk in everything else that we give steroids for. The steroids kick in an hour or two down the road. They're not instantaneous. So if we give IV steroids, whether it's Decadron or Solumedrol or whatever, they're for an hour or two down the road. And then if we get the patient better and they go home, they generally go out on prednisone for a few days. But starting steroids early is a key. And so what we're doing with the steroids is reducing the inflammation in the airways. So we gave the bronchodilator to dilate the airways. We're giving the steroids to reduce the inflammation. That helps clear the mucus. So we've dealt with all three of the components of asthma, if you will. Magnesium, we don't carry, but it's relaxes smooth muscles, and you give over 30, 60 minutes. In patients who are in what we call status asthmaticus, they're just not getting better or getting worse, magnesium many times will help keep them out of trouble. And then obviously we give them oxygen to keep their sats above 92%. This is an old treatment. Back in the old days, we used epinephrine, we used terbutaline, we used all kinds of injectables. Epi's kind of a last-ditch effort. If they can't tolerate an aerosol and they're getting into trouble, 0.3 of 1 to 1,000 epi IM is still in the toolbox. So when you hear someone wheezing, and you think, all right, it's asthma. Well, yeah, it probably is. What else could it be? Well, certainly could be COPD. It certainly could be pneumonia. And patients with asthma get pneumonia and they get other problems. They get congestive heart failure. So many times these patients come in with a mixed bag. In kids, you think of RSV. We're coming into the cold season, respiratory syncytial virus. It presents, these kids come in and they've got, it's classic, it's green-gray snot out of their nose and they're wheezing. And you do an RSV nasal swab and it's positive. And there's been all kinds of treatment theories and things change. We inevitably give them aerosols. We inevitably give them steroids. And the fact is, it's like a cold. It runs its course over 3 to 5 days. But when you hear wheezing and snotty-nosed kids, you think of RSV. Congestive heart failure, people wheeze with congestive heart failure. You walk in, we call it cardiac asthma. They got a little bit of fluid in there, and yeah, you might hear a few rows. What you hear is wheezing, and you start looking, and they've got big neck veins. They got swollen ankles. Yeah, they're having a little congestive heart failure with that. Pulmonary emboli can do it. Inhaled foreign body. You don't see this very often, but if you ever see a patient that has wheezing on one side, and it will generally be on the right side, but it's only wheezing on one side in a local area, particularly if it's a kid, you think, I wonder what they swallowed. They got something down there stuck in the airway, which is causing them to cough and wheeze. A lot of patients that come in with asthma-like symptoms, when we finally get to the bottom of things, they got reflux. They're refluxing acid and just a little bit's going back down there and just enough to cause bronchospasm. And you put them on some Nexium or Prilosec or something like that, and all of a sudden their asthma goes away. COPD is a little more ominous long term. It really has two components. That is chronic bronchitis, which is just recurrent inflammation of the airways and we flare and so forth, and emphysema. Emphysema is kind of, it's the non-reversible part. That is really destruction of alveoli. So instead of having all these tiny sacs, the walls begin breaking down, and now you're getting bigger sacs. So the surface area is not as much for gas exchange, and that's why the patients get into trouble. Smoking's the leading cause, so you see patients who say, what you got there? Well, I've got COPD, I've got chronic bronchitis. Get emphysema? No, they told me I don't yet. Yeah, you probably will at some point. 10% of hospitalizations, not a real seasonal illness with it. It is almost 100% tobacco related. 15% of smokers who smoke more than a pack a day will get COPD. Uh, so you talk about a cost of tobacco, that's a big one. And most of these folks have smoked more than a pack a day for 20 years. And you talk about what's COPD feel like. It's literally put a clothespin on your nose, get a straw, and try to breathe. You can get air in. You can eventually. It takes you a long time to get it in. Trying to get it out. Trying to get it out. And so smoking is really the problem. These people who become terminal with COPD have just miserable existence at end of life. And the rate that it develops is like we see in so many other illnesses. It's when did it start? What was the physical condition of the person before it started? In the age, when smoking began, and are they still smoking with the oxygen on and so forth? And really, the progression is depends on a lot of other factors. But every time someone gets a COPD flare, and these folks will get 2, 3, 4 year, what happens is they're going along at baseline and they get a flare, then their baseline drops a little bit. The next flare, their baseline drops a little bit. So every flare that they get of having to go to the hospital, having to get antibiotics, having to get steroids, if you looked at lung function each time, then it's just a little bit worse. And that's the nature of the illness. And most of these flares, they're susceptible to infections. They've got mucus in there they can't clear, get a little exposure to a virus, or they get a bacterial illness, and all of a sudden, here they are in trouble. What's interesting is the COPDers come in short of breath. We always think, yep, they're having a COPD flare, and maybe they got chronic bronchitis. They're the ones who also have a high incidence of pulmonary emboli. And so every time you see somebody that's short of breath, maybe they got pleuritic chest pain, it's like, all right, do they have a blood clot in their lung as well? So this illness doesn't only affect the lungs. We all know somebody with COPD. We've seen patients with COPD. But think about the patients that you know in your community who've had COPD or emphysema for a long time. What do they look like? And it all looks the same. These people all have these wrinkled faces. Hypoxia and tobacco kills the elasticity of our skin. You walk in a room, you look at these patients who just have these terribly wrinkled faces, and I start thinking, okay, how much did they smoke? What they got? They've got impaired gas exchange, and they're chronically hypoxic. So they chronically have low oxygen. So they have muscle wasting. Their chest gets big because they've got chronic air trapping. So they've got big chest, muscle wasting, and that's kind of what they look like. But then if you look deeper, you'll find if you drew a blood count that their red blood cells, their hemoglobin, is high because the body's trying to make more red cells to carry more oxygen. And now they've got thicker blood that's harder to pump. They're getting some right heart failure because as you get that barrel chested, the pressures in the chest are up. So now the blood can't return quite as easily because there's pressure in the chest that kind of keeps it away. They get muscle wasting because there's not enough oxygen. And so it's a disease that affects the entire body, not just the lungs and the respiratory system. But in COPD and emphysema, you damage the alveolar walls, you lose them, then they become bigger sacs. You don't get the gas exchange. And what happens is these people reset how they think to breathe. None of us right now are thinking about breathing. We've got receptors in our body, in our carotids, in the brain, that are detecting our carbon dioxide level. That's our driver for breathing. As your CO2 goes up a little bit, it's time to take a breath. These guys have chronically elevated CO2s. We talked about it rises. So their body is now really using oxygen levels as the driver to breathe. because they've got chronically elevated carbon dioxide levels. So their bodies, the receptors are saying, okay, when the oxygen drops, I need to breathe a little faster. So what's that mean to us in the field? What happens when you put oxygen on that guy? Potentially, they lose their drive to breathe. Yeah, and that's why it happens. Is their body is not like ours. We're, you hold your breath, you can hold it so long, CO2 goes up, you're going to breathe. Their oxygen level goes up, they're going to stop breathing. That's what happens. So everything changes. They get air trapping, they get chronic hypoxia, they get chronic hypercarbia, elevation of CO2, and hypoxia becomes the driver for respiratory rate. So we've got to be careful with these folks when we encounter them. We never withhold oxygen. You just have to know if you're going to give oxygen, you got to watch, because you may end up having to help bag this patient before it's over with. You didn't do anything wrong. It's just we got to get them through this crisis. So they get short of breath. They start coughing up sputum. They can't walk down the hall. There's no exercise intolerance. They wheeze. Chronic COPD or with emphysema, you listen, their lungs are quiet. They're just not moving any air. They got no alveoli. You put pulse oximeter, 92% is pretty good for most of these folks, and a lot of them are on oxygen 24 hours a day. So it's a tough illness. So what do we do, or what's the critical findings? Just like in asthma, oxygen saturation low, respiratory rate fast, skin discoloration, mental status changes. In many cases, that's due to CO2 retention. And what they really need is ventilated. They need, more ventilation, not more oxygen. So we get them oxygen to keep their sats above 90, 92. We give them inhaled beta agents. We give them steroids. CPAP or BiPAP, that is giving some positive pressure on inspiration, in many, many cases is useful. But we don't withhold the oxygen, but we do watch for respiratory depression as we give oxygen, because we may be suppressing their drive to breathe, and we may need to help them ventilate. Pneumonia, we've talked about air trapping diseases. Now we're going to talk for the next 5 minutes or so about pneumonia. Basically, it's a lung infection. You got pus in the alveoli. Classic fevers, chills, cough, short of breath, coughing up nasty stuff. It's pneumonia until proven otherwise. It's really, really common, and it's really, really deadly. If you take someone over 60, 70 years old, they get a community-acquired pneumonia. Untreated, it's got a 1 in 3 mortality. And people in this day and age still die of pneumonia. And in fact, in flu season, it's pneumonias that kill people. Now, it's a viral pneumonia in that case, or a secondary bacterial pneumonia, but it can be a bad illness. And obviously, the mortality increases with age and other illnesses and so forth, particularly diabetes or COPD. But the key points when we are looking at somebody considering pneumonia, is that what it is? Fevers, chills, cough, short of breath, fatigue, get up, walk around, they get trouble breathing. I had a patient about 3 weeks ago that was in this classic category. He had what we call quiet tachypnea. Walk in the room, guy is, I think he's in his 70s. He had a temp of 102, blood pressure at 90 systolic. And he's sitting there talking to me, but you watch him breathe, and he's just, he wasn't rattling. He didn't look bad. He's breathing about 30 times a minute very quietly. Quiet tachypnea. He's very quietly breathing fast. And he had low blood. He basically was in septic shock. It was a form of distributive shock that we talk about. And so this guy was on the cusp of going down the tubes. His oxygen saturation is like 92%. His blood pressure's low. He's sitting there working to breathe. He'd been like this for a couple of days, had a cough, fevers, chills. Sure enough, you get a chest x-ray, and there's the answer. But then you go looking at other factors, and he had new onset atrial fib, and which probably was due to the pneumonia and the hypoxia. So that's what happens, is people get sick from one illness, particularly if you're a little older, and then other things start going south. you know, as many things we talk about, if you've got pneumonia, complicating factors, if you have an immune system illness, if you have HIV disease, the the you got to think of different organisms causing the pneumonia. If you've got congestive heart failure, one of the difficult diagnoses we do in the emergency settings, patient comes in, get a chest X-ray, and you're looking at it and saying, well, is that pneumonia or is it failure? Or is it both? And many times it is. And diabetes complicates everything. Said it before, say it again. Patient with diabetic, everything's complicated. People with COPD, people with asthma get pneumonia, and they're complicated as well. So again, supplemental oxygen for everybody. Get the SAT above 92%. CPAP, putting a little pressure in the airway so there's always pressure there. What we call recruits alveoli, keeps them inflated. That's real important with pneumonia. Aerosol treatment, IV hydration, particularly if patients getting sick. They may be getting into a form of septic shock, so we want to, they're not low on fluids, the vessel's too big, so we want to fill the vessel up with fluids. And then we want to get IV antibiotics in as quickly as possible. And this has been proven time and time and time again to be a factor in survival. And we all know it's nothing malicious that happens, but let's say that we're transferring a patient from one institution to another. So let's say we're going from my clinic to a major medical center. What happens to the patient when they get to the major medical center? They got to go through triage, got to do this. So they could be delayed a couple hours getting antibiotics. And so the point is, these are patients when they show up in an emergency department, they show up in a clinic, timed antibiotics in pneumonia survival is very, very important. So in summary, we talk about respiratory distress, and we've talked about 3 illnesses tonight. You got to look for signs of respiratory distress. You guys recognize that when you walk in a room. You know what you're looking for. You want to look at what their previous illness history is, if they had respiratory problems before. I always treated as an emergency physician asthmatics and COPDers very aggressively because these are patients that can easily get tucked away in a corner and they can go down the crapper on you. And so respiratory illnesses are ones that in every case, and particularly kids, can decompensate. So someone's short of breath, they're breathing fast, you gotta get on them. You gotta get them oxygen. You gotta get them albuterol, and you gotta monitor them closely and keep a close eye on them. That's it. Any questions? Yes, sir. Right. Yep. Right. Sure. And it's interesting. There are, so let's take asbestos as a good example. Asbestos, asbestos exposure is bad for you, coupled with smoking is really bad. My dad worked in the printing industry. He was a linotype operator. Back in those days, they used molten lead. They literally melted lead and set the type. So Dad was breathing these lead fumes all day long, and then he smoked all day long. Well, which caused his lung cancer? And which caused the lung cancer of the other 8 guys he worked with? Who knows? I mean, that's what everything that you take that causes a respiratory illness is made worse by smoking. Now, the question is cause and effect, but yeah, if you're working around toxic fumes, you're working around some of this stuff, and today stuff that we wouldn't dare work in an environment without a non-rebreather or some kind of filter mask. 40s, 50s, 60s. That's just what people did. So, but in every case, smoking may not have been the cause, but it certainly made it worse. And that's what I tell people. And it's interesting, we're seeing young people begin to smoke, and from a standpoint of heart disease, the day you quit smoking, literally, your risk of heart disease starts dropping off. and I forget what the number is, 3, 5 years out, you're back to a non-smoker's risk. If you can quit smoking before you have permanent damage, emphysema, then some of the lung changes are reversible to an extent. But once you have smoked your way into emphysema and you've destroyed those alveolar walls, there's no reverse. And that's the problem with so much of our respiratory illnesses. Uh, and so, we still will have, as long as we have, I think that, the days of crawling in a building on fire without a breathing apparatus on to show you're a man are over with. The days of working in an environment with, toxic fumes that we know are over with, but the days of smoking aren't over with. So. All right, guys. Well, thank you so much. It was good seeing everybody again. I think our next one is what, August? I think it's October. I'll look at the schedule. Whenever my calendar says I'm back, I'm back.